A 42-year-old male patient presented with left hand weakness. On MRI brain T2 weighted sequence, you are seeing a large extraaxial cystic lesion without any communication with the ventricles. It is causing the gray matter buckling, smooth indentation without causing any significant edema. There is also white matter compression. So, all these features are pointing towards a classical arachnoid cyst because it is following the CSF signal intensity. Subsequently, this patient didn't have any diffusion restriction or flare didn't show any debris. This is sagittal weighted just to impress upon how the surrounding structures, there is some mass effect, venous structures, also some calvarial thinning compared to the normal calvarium. Here, there is calvarial remodeling occurred without any obvious destruction. Arachnoid cysts are benign cerebrospinal fluids containing lesions. They occur throughout the central nervous system. Understanding the radiological features of arachnoid cyst is crucial for accurate diagnosis. The cortical buckling phenomenon occurs because they are extraaxial masses, typically preserve the cortical architecture while compressing underlying white matter. This creates characteristic frond-like distortion, which was very well seen in my case, that appear as curved buckled white matter. CT imaging features are they will present with imperceptible walls and routine imaging, CSF equivalent density, no contrast enhancement, displacement of adjacent structures, potential bone remodeling. These are the features on CT. And how will you differentiate from other epidermoid is there won't be any diffusion restriction, and flare it will be homogeneous signal intensity following CSF signal. And also phase contrast can help us to identify some flow. Some arachnoid cysts communicate with the systems and there will be flow within arachnoid cyst. Those are called communicating arachnoid cyst. And diffusion restriction will be there in the closest to differential diagnosis epidermoid, but not in the arachnoid cyst. Flare there will be debris and dirty CSF appearance in dermoids or epidermoids, unlike the arachnoid cyst. A Galazi classification is there for temporal pore arachnoids. Simple arachnoid cyst which is not occurring or entering the sylvian fissure is type 1. Type 2, there will be extension to sylvian fissure. Type 3 is a huge cyst with lot of mass effect. These things you should know. When the symptomatic presentation, there can be a surgical cystoperitoneal shunting they may do when it is a huge cyst. The mass effect is there. So in summary, CSF signal matching, cortical buckling, diffusion restriction absence, wall visualization on routine imaging is very difficult. Mass effect patterns also are helpful in diagnosing the arachnoid cyst. Thank you very much. Identifying the arachnoid cyst from other conditions is very, very important. Diagnosing it as an extraaxial lesion is important.